Our next magnificent speaker will brief us on MR enterography, applications, technique, and image finding. Dr. Dunda Brown. Dr. Dunda Brown is a diagnostic radiologist specialized in the abdomen and GI system. Dr. Brown is the major author and editor for 3 medical textbooks and has over 120 publications in peer-reviewed journals and book chapters. Please join me welcoming Dr. Linda Brown.
Thank you. This is my first on-site lecture since COVID, so it's my great pleasure to be here and participating in ASEAN Gastro 2022. My topics today is MR enterography, and I want to focus only on Crohn's disease for today's discussion. And here is the outline of my talk. I will start with brief introduction, and I will focus on MR enterography and Crohn's disease, and I will show you several cases of Crohn's disease and its mimickers, and then conclusions. What is MR enterography? MR enterography is a non-invasive imaging technique for diagnosis of small bowel disorders. It has some advantages to use MR enterography, which include no ionizing radiation, excellent soft tissue contrast resolution, and we could have images in multiple planes. But there are some weaknesses in using MR enterography, which include long scanning time, particularly when compared to CT enterography. And also the technique is more susceptible to motion and breathing artifacts, which sometimes giving the images not so easy to evaluate. Having said that, it is really, really good modalities for evaluation of the small bowels. Technique is also simple. Patient needs to NPO for 4 to 6 hours, and then we need to distend the small bowel so that we could visualize it. And we use solutions, some solution, and there are different solutions that you can that could stay inside the small bowel long enough that we could visualize it. But in my practice, I use polyethylene glycol, and the trade name you probably all know, like Forlax or Niflex. In that way, we use the same solution as the colon bowel prep, but we have the patients drink it about 1.5 liter in intervals for a duration of 45 minutes, and it will stay, it will distend to the terminal ileum. We have to tell the patients that after the study, they might have some diarrhea because of the effect of the solution. And we tend to use Buscopan after cine sequence and before intravenous contrast because this is sensitive to motion. We give Buscopan to decrease the peristalsis. And then for pulse sequences, we use T1 and T2 pre and post gadolinium. And mostly we use coronal view as the basic image because we could cover the whole range of the small bowel. Let me show you a normal. I don't know if it projects well or not. This is normal MR enterography on T2. You can see that on T2, the bowel will look bright because of the fluid, and you will see the wall is thin, and valvular conjunctivitis is normal. So this is a normal MRE on T2 single shot, which is very fast. And we also perform so-called T2 cine. Cine means movie view. So in this way, we could see the peristalsis of the bowels. You could see here that some movement of the bowels. And if there is segment that doesn't move very well, we could see it. So it's a good tool to see the peristalsis of the small bowel. And then we use T1 pre and post contrast. On T1, the fluid within the bowels will become dark. T2 will be bright, T1 will be dark. So as you could see here, and when you give contrast, you enhance the wall of the small bowel because it has a lot of blood supply. So you will visualize the bowels nicely on pre and post contrast. So this is an example of normal MR enterography. So what is the applications of MRE? Most commonly, we use it in Crohn's disease. This is the reason behind this is that Crohn's disease tend to occur in young population. And the study needs to repeat multiple times, multiple follow-up. So we don't want to use CT in young patients multiple times because of the effect of radiation that could have the risk of radiation-induced cancer. That's why MR enterography has the role in Crohn's disease the most. But you can also use it in other diseases like celiac disease, adhesion, enteritis, scleroderma, malignancy, other diseases you could see it too. But it's easier to do CT enterography for these diseases. But if you want to use MR, it's also a good tool to use. Today we will focus only on Crohn's disease because it's the most commonly used in MR enterography. Let's focus now on MR enterography and Crohn's disease. As you all know that Crohn's disease is a chronic inflammatory disorder that can occur anywhere in GI tract, most commonly in the terminal ileum and colon. And the lesions are transmural, which can lead to a complication of penetrating diseases such as stenosis, fistula, and abscesses. And currently, MR enterography is considered a primary cross-sectional imaging modality for assessment of Crohn's disease. What is the role of MRE in Crohn's disease? We use MRE to define the extent of the disease, to assess disease activity, and to evaluate complication and response to treatment. And this is a nice diagram showing multiple manifestation or stages of Crohn's disease, which we could see on MR enterography. It could present with non-specific inflammation, just a little bit of enhancement of the bowel wall, and it could progress into active inflammation, which you could see as thicken of the bowel wall with some mucosal irregularity, with or without upstream dilatation. But if the thickened bowel wall progress into area of stricture, which causing upstream dilatation, it could progress into a transmural inflammation and developing into a complication of sinus tract, fistula, or inflammatory mass and abscesses. At the same time, this active inflammation could revert back to normal with some treatment, particularly some good medical treatment. So you could see Crohn's disease patient back to normal bowel study or just some inactive quiescent fatty infiltration. So it go back and forth all the time in terms of Crohn's disease. What is the imaging findings of MR enterography in Crohn's disease? I will separate it into three groups: bowel wall findings, mesenteric findings, and complication of penetrating Crohn's disease. And this is the summaries of bowel wall findings, which I will show you on the real cases. But in summary, the bowel wall findings include wall thickening, mural hyperenhancement on post-contrast, mural edema, stricture, ulceration, sacculation, and decreased motility. For mesenteric finding, you will see perienteric edema, inflammation. You could see engorgement of vasa recta, the vessels along the mesentery. Sometimes we call it comci, which I will show you. Or you could see fibrofatty proliferation of the mesenteric fat, so-called creeping fat site. And sometimes we could see thrombosis, occlusion of mesenteric veins, and reactive lymphadenopathy. This is our mesenteric changes. And when the disease develop into transmural penetrating, we will have complication of sinus tract, fistula, which would be simple or complex, inflammatory mass, abscess, or free perforation. So let's see it in the real cases. Those are like a quick summary for you guys to know how we look at it now. I will show you the real cases of Crohn's disease. I will show you 6 cases of Crohn's and its complication, and I will show you some mimickers of Crohn's. Let's start with the first case. This is a young gentleman, 17 years old, already known Crohn's disease. He presented with hematochezia and weight loss. This is T2, axial and coronal view. I hope that you can see it. You can see here that there is diffuse thickened wall of the terminal ileum and ileocecal valve. See that? It's narrow, the lumen. The lumen is bright. The normal bowel wall should be thin like this. So this is absolutely abnormal. And this is the coronal view. As you could see here, that there is thickness about 10 millimeter with a luminal narrowing. And when we give contrast, you can see there is diffuse enhancement of this thickened wall, as you can see here too, with a luminal narrowing. So this is tell you that these patients still have an active inflammatory of small bowel Crohn's disease with luminal narrowing, but no upstream dilatation. This is a classic Crohn's disease in the active phase. Let's go on to case number 2. This is again another young gentleman, 27 years old. He has known Crohn's disease of the colon, now presented with diarrhea and bloody stool. I show you here T2. It's a little bit dark there, but I want to show, like here, see that? The thickening of the sigmoid colon there, all the way up to descending colon. So it's involved the colon in this case. And when we give contrast, you can see here that there is diffuse enhancement of this part of the colon. This is better magnified view, as I show here, that there is thickened nodularity, almost like cobblestone on the GI, long GI study, and there's some ulcer right here. So right here, this is an ulcer. And here, there is diffused, thickened wall of the colon. So this is an active phase of colon, Crohn's disease of the colon. As you go down here, there is fistula. You see that? There's also another manifestation of Crohn. This is intersphincteric end of fistula. This is post-contrast, and this is T2. So in this particular case is an example of active inflammatory Crohn's disease of the colon with low intersphincteric end of fistula. So it's a very exquisite way to look at it. This is another case of a young man with known Crohn's disease. Now he presents with clinical obstruction. So you could see that there is a lot of dilated loop of the small bowel here, here. And then you see that the site of obstruction is down here, that there and there. So this is an area where there is diffuse, thickened bowel wall with narrowing with stricture. I show you the view of cine views, and this is peristalsis of bowels up to upper small bowel, and here's a dilated bowel loop. It has some peristalsis, but you can see that it's sluggish. But notice this loop here, which is abnormal. It shows stricture, narrowing, and it has motility is much decreased or almost none. Yeah, look at it again, see that? No movement of this segment of the bowel wall. So on post-contrast, you could see that this segment that is narrow stricture show enhancement, show mural enhancement suggestive of active inflammation with strictures. And in this image down here, you could see that there is right here, there is almost like a bow tie because the bowel loop comes together like a stellate appearance. Is tucked in because of fistula, and fibrosis. So it become a complex enteric fistula. This pattern sometimes we call cloverleaf or bow tie appearance. And in this image here, you could see that there is some lymphadenopathy, which is quite common in Crohn's disease. This is a reactive lymphadenopathy. So in this particular case, it is an active small bowel Crohn's disease with complication of transmural penetrating disease of fistula and stricture with high-grade small bowel obstruction. When there is high-grade small bowel obstruction, your medical treatment cannot treat it. You know, you have to try to treat it before it turns stricture. So one is stricture that you have to go for surgery. So in this case, surgery was performed with light-sided colectomy and aerial resection. And pathology confirmed mixed acute and chronic inflammation with transmural changes consistent with Crohn's disease. Another case of 45 years old male, again, non-Crohn's disease, present with persistent abdominal pain and clinical obstruction, nausea, vomiting. Again, MR enterography was requested to see what is the extent of the disease and how the disease activity is happening. So this is a T1 post-contrast, and this is T2. You can see here that there are two sides of stricture. Right here, 1 and 2 here. So stricture could happen in multiple foci, which is common in Crohn's disease. So we have to look the whole small bowel. So you can see that there is the stricture of two sides, and there is markedly dilatation of the upstream bowel loop. And the side where it's stricture, it's show mark enhancement, suggestive of combination of active inflammation with fibrosis. And you can see here that there is marked fatty proliferation, the mesenteric fat. It's abundant, it's increased. This is the so-called creeping fat sign. And if you look at here, there is increased engorgement of vasa recta. It doesn't show up very well there, but this is a side that we call comb side. So comb side, creeping fat side is the side of mesenteric inflammation. And because of the involvement of the mesenteric fat and fibrosis is marked on mesenteric side, you can also see the finding that called sacculation right here. So that is all the finding that is compatible with Crohn's disease. And this is a spot that when we look at axial view, you can see that there is diffuse enhancement with some of soft tissue here, which we think it's the fibrosis with active inflammation. So at this point, our impression is that this gentleman has active small bowel Crohn's disease with complication of penetration of strictures and obstruction with upstream dilatation. Again, once there is obstruction like this, there is a role of surgeon to come in. So in this case, a jejunal ileal resection was performed. As you can see here, that there is a narrowing with increased vascularity, which is the area of inflammation. Pathology shows acute and chronic inflammation with transmural changes compatible with Crohn's disease. But to our surprise, pathologists also detect foci of invasive adenocarcinoma well differentiated. So small bowel adenocarcinoma and Crohn's disease, it's not common, but the risk was increased by about 64 compared to general population. And in general, imaging techniques may miss small lesions and may not be able to differentiate area of small bowel carcinoma, which is an infiltrative type, from a very stricture of Crohn's disease. So it's very difficult for us. We usually cannot pick it up unless it's a big mass. If it's infiltrative, imaging is hard. And it is often diagnosed after resection, and pathologists review the specimen and found it, which is similar to our case. And the prognosis of Crohn's associated small bowel carcinoma is poorer than the de novo small bowel carcinoma. So this is a very interesting case that we run into a lot of Crohn's disease, and we just found one case of adenocarcinoma. Another case, this is a gentleman, 30 years old, again, known Crohn's disease, presenting with weight loss. also sent to us to evaluate the extent of the disease and the activities. So the first one is T2. This is T2, and this is T1 post-contrast. You can see here, around here, there is that bow tie appearance. There is diffuse thickened wall of the small bowel, and there is the loop of the small bowel tucked in together, giving a bow tie, the cover leaf appearance. This is the finding of enteric fistula. But here is the bladder. This is the bladder here. So there is also fistula to the bladder, and this is the inflammatory within the dome of the bladder. Post-contrast show enhancement. So this patient has a complex fistula, enteric bladder fistula. And as we moved in another cut, we detect this big mass here. See that? This is a large lymph node, mesenteric lymph node. It's too big to be reactive lymphadenopathy that we see in Crohn's disease. It looks like a pathological node. Since we see adenocarcinoma, we start to think that this case might have some kind of neoplasm, but we don't know what it is. It could be adenocarcinoma, it could be something else. So because of this area of multiple complex fistula, a surgeon came in and performed ileocystectomy with removal of these huge lymph nodes. And pathology confirmed Crohn's disease, and these lymph nodes, it turned to be non-Hodgkin lymphoma, which is very unusual too. So lymphoma, it's quite rare in Crohn's disease, but it has shown to increase risk. I don't know how often you guys see Crohn's or adenocarcinoma in patients with Crohn's disease, but it is believed to associated with EB virus and the use of immunosuppressive therapy, like thiopurines that used commonly in inflammatory bowel disease. And I think we probably have to keep an eye on some of these neoplasm. And this is case number 6 that I will show in Crohn's disease. This is a 57-year-old gentleman with inactive Crohn's disease. He used to have Crohn's disease around some time ago at terminal ileum and ileocecal valve. Now he wants to evaluate to see how the disease activity is doing. He feels fine. This is T1, and this is T1 post-contrast. And you could see here that ileocecal valve and terminal ileum looks okay, but it's hard to see here, but it's too bright. Usually we have to have dark room, but there is a line of fatty deposition right here. And when you give contrast, it's around here. It's hard to see, but it's a thin line of fat deposition around the previous inflammation. This is CT. See, that CT is easy to see than MR. This is CT of the same patients as, and you can see fat. You can see that, the black line along the contrast that fill in the lumen. So that is the fatty deposition in the previous Crohn's disease with no imaging sign of active inflammation. So if you treat these patients well, they could revert back to normal. So that is what we like to see. But often it also progresses into active disease again. Let me end up with 2 examples of Crohn's mimickers that are sent to us in MR enterography. This is a female, 51 years old, presenting with abdominal pain and weight loss. This is a patient that come from Middle Eastern region, which is Crohn's disease is quite common. So that's why when person presented this way, clinicians think, oh, maybe it's Crohn's disease. They send for MR enterography to see if it's Crohn's or not. And this is T2. It moves so fast, but here it is. You see that? There is diffuse thickened wall of a long segment of the small bowel. And when we give contrast, see that? There is a lot of enhancing walls, transmore enhancement, it's diffuse. But let's look at here. See that? Diffuse thickened wall, too long, right? But Crohn sometimes could do this. But the point is that this is ileocecal valve here. It looks normal. It looks normal. Crohn's tend to involve IC valve and terminal ileum. This is involved a large part of small bowel, but IC valve is normal. So we said this is a non-specific small bowel inflammation. It could be Crohn's, we don't know. So it's your job to biopsy it. So you went in and performed endoscopy. And no surprise, non-specific inflammation. We still cannot tell what it is. Fortunately, the blood tests show eosinophilia of 32%. So at the end, we think this is eosinophilic gastroenteritis. Treatment was given and follow-up, it's normal. So this is Crohn mimicker. This is my last case. This is a 34-year-old gentleman, again from Middle Eastern region, presenting with abdominal pain, rule out Crohn's disease, sent to us by gastroenterologist. This is a cine movie view. You can see here that there is a normal peristalsis of the small bowel. I want you to focus around left mid-abdomen. So you can see here that there's a dancing of the peristalsis, and even the bladder, you can see the movement. Everything is moved, so they have life inside your abdomen. They keep moving alive, but look around here. Something will pop up, and this is cine wheel sometimes. This is the one that helped me pick up this lesion because I do not expect this right here. Look at here. Something pop up, right? See that there's something in the lumen here. Yeah. So this is the static view. This is T2. You can see the mass here. This is post-contrast. That's diffuse enhancement. Also true on the axial T2 and post-contrast. The mass is vascular with relatively smooth surface, probably originate from the wall of the small bowel. So our impression is that this is probably a small bowel neoplasm. There is no evidence of active small bowel inflammation. And our differential diagnosis is just NET and adenocarcinoma. So surgeon come in, perform laparoscopic jejunal resection. This is the image on laparoscopic view, and this is the surgical specimen. And this is the bivalve pathological specimen. And pathology show this is a gastrointestinal neuroectodermal tumor. This is not neuroendocrine tumor. This is a malignant tumor of the small bowel. It's kind of in the family of sarcoma. It's more aggressive. So the patients will have chemotherapy after this. So in conclusions, MR enterography is a non-invasive technique for diagnosis of small bowel, and it is considered a primary cross-sectional imaging for assessment of Crohn's disease. And I show you guys several cases, and it's mimicker that I hope that I entertain you somehow. If you do not learn anything, at least entertainment. And I'd like to thank my colleague, Dr. Mayuriwan from Bamrungrad International Hospital. She provided me of many beautiful cases I show for you today. And I thank you all for your attention.
Thank you, Dr. Linda Bao, for the excellent talk. Any question from the floor? Professor Rajagon.
Linda, thank you so much for your great talk as always. Just briefly let you know that we have many participants online, and the participants from Japan said that your talk is very excellent.
Oh, thank you. That's a
so
good
you're not all
comment.
alone, all right?
Thank you.
So to be honest, I believe that as a gastroenterologist, we get very familiar with the CT colonoscopy or even the CT scan for the bowels. So in your ideas, in your suggestion, when we have to choose between the MR enterography and the CT enterography, which one we can use and which condition you suggest for?
Yeah, CT enterography is also a very good tool. It's easy to do, it's fast, and it's the image is more easier to interpret. And I would say that if the patient is not young, and you just do it once or twice in their lifetime, you go for CT enterography. But if Crohn's disease, you know, the kids sometimes 12, 13, 14, or even early 20s, and you have to do it every 3 months, 6 months, a lot of radiation if you perform CT. So that's why MR enterography has the role in Crohn's disease. But if people just scared of radiation for whatever reason, you can always do MR enterography. And the technique is really now fine-tuned it nicely. But CT enterography is also a great tool. And we use the same bowel distension, and it just faster. 30 minutes is done. MRI probably 1 hour or 2 hours. Yeah.
Okay. Thank you for Sister Linda. That is a very impressive lecture.